I will be, I will be with you through this course, teaching you the some GI knowledge about gastrointestinal disease. I have 3 lectures today which are very important for you in your career, like the chronic liver disease and diabetes, and the approaching of patients for acute diarrhea and for chronic diarrhea and malabsorption. So listen to me, because the word that I give you here in the lecture usually it will be practical, and most of the questions that comes in the MCQ or in the practical exams come from this lecture, from these words. So if you understand what I'm talking about, so we're gonna answer all the questions. And it doesn't matter to answer the question, the matter is to become a smarter and approaching the patient in the right way. So let us start with the chronic liver disease. So here some learning point. This is the aim of the lectures. And we will start with the definitions of cirrhosis. Cirrhosis is histopathological definition. So when I say histopathological definition, it means you have to take a biopsy in order to define the histology of the liver. So as you know, we have 4 stages of fibrosis: F1, F2, F3, and F4. I will gonna show you what is the difference between each of those. Okay? So F1, F2, F3, and F4. The final stage of liver fibrosis is called cirrhosis. So if anyone asks you what is the liver cirrhosis, you say F4, the final stage of liver fibrosis. So it is a late stage of progressive hepatic fibrosis. And it is a final pathway for all chronic liver diseases. So as you know, we have acute inflammation, acute hepatitis, and we have chronic hepatitis. So when there is an insult for the liver, it starts with acute inflammation, as you know. And then, if this insult continues for a while, it will heal by fibrosis. And then, the fibrosis will progress and lead to the liver cirrhosis if we continue to the stage 4. So, what you will find in a patient with cirrhosis is when the histopathology or gross anatomy will see distortion of hepatic architecture and formation of liver nodule. If you can see the pictures on the panel, so this is the normal liver above, and below the usual pictures of liver with cirrhosis. So it is distortions of the normal architectures of the liver and formation of full-blown nodules. On histopathology, you will see these pictures. This is the normal, this is the acinus. This is the acinus here. And this is the portal tract. It's surrounding the liver lobules or liver, what is called the functional unit of the hepatocyte, of the liver. When there is full-blown pictures of the nodules, this is the fibrous band extending through the portal side. It's formed what is called liver cirrhosis. As I told you before, we have 4 stages of liver fibrosis. And there is a famous score called Meta-Baird score, which is the histopathological score. If you can see, this is the portal tract. There is beginning of the fibrous band in the blue appearing in the stage 1. Stage 2, F2, the fibrous band start to extend to the nearby portal tract, but it is not connected. In F3, the fibrous band start to connect between each other, but till now there is no full-blown pictures of liver nodule, and all the bands connected each other and form full-blown pictures of of liver nodule. At this time, we call it F4, stage 4 liver fibrosis. And this is the pictures of liver cirrhosis. So simply, fibrosis have 4 stages: F1, F2, F3, and F4. F1 means there is mild fibrosis, F2 moderate, and F3. And F4 is the formation of liver nodule. Usually the patients, if they have F1 and F2, usually the cause, if you treat the cause, you will revert the patient to the normal state. But if the patients have F3 and F4, it's very difficult to return back the patients to the normal stage. So please guys, when anyone asks you, what is the liver cirrhosis? The answer is the F4. The answer is the last stage of liver fibrosis. What is the name of the stage? Is F4. Okay? Is that clear? Okay. This is very important slide. Till now, I applied this slide when I'm approaching any patient. We have many causes for liver insult. There is toxic causes for liver insult. The first cause is the alcohol. Many people drink alcohol, especially in Western countries, a social habit. So when there is chronic high intake of alcohol, it leads to liver inflammation, and this liver inflammation leads to the liver fibrosis. So in approaching any patients coming with the liver inflammation or liver fibrosis, so the first question to the patient, do you drink alcohol? Because you need to connect this inflammations or fibrosis caused by alcohol or not. The second most important cause for liver inflammation and fibrosis is a chronic viral hepatitis. And we have 2 viruses, B and C. Someone of you, why don't mention the hepatitis A and others, E and D? Because it's causing only acute, causing only inflammations. It doesn't cause fibrosis on the long term. So it doesn't cause chronic inflammation. But B and C can be hidden in the hepatocyte and cause mild indolent inflammations for a while. And this causing the patients to have chronic inflammation, and chronic inflammation leads to the fibrosis. The disease of the era nowadays, obesity, and caused by fatty liver disease, caused by diabetes mellitus, and by obesity. So, fatty liver disease, many patients, they got obese, and they don't know whether they have steatosis or not. First stage of the liver, fatty liver disease is steatosis, and then will cause inflammation, steatohepatitis, and then will lead to the chronic inflammation, lead to the chronic fibrosis, and then it will lead to the cirrhosis. And we have many patients living with liver fibrosis and steatosis, and they don't know because they don't check. I will come to talk about the symptoms of liver disease. Liver doesn't cause any symptoms, even when you have cirrhosis. We'll come to see what is happening in the symptoms. But let us finish the causes. Biliary causes. When there is injury or inflammation of bile duct, it will lead to the chronic inflammation again and chronic fibrosis. Example of that, primary biliary cirrhosis, primary sclerosing cholangitis, injury, iatrogenic injury, cystic fibrosis. These are what we call is the most common causes for liver fibrosis. Of course, we have many rare causes like congenital diseases like hemochromatosis, accumulation of iron inside the hepatocyte. And this accumulation of the iron will lead to the chronic inflammations, and the chronic inflammation lead to the chronic fibrosis. And then it will lead to what? To the cirrhosis. The third, accumulation of copper. The copper It leads to the, again, in case of Wilson disease. Accumulation of iron happen in case of hemochromatosis. Accumulation of copper happen in Wilson disease. All these are congenital anomalies, congenital inflammations, and metabolic disorder would lead to the chronic inflammation and chronic fibrosis. Alpha-1 antitrypsin. Sometimes we search for all these causes and we couldn't find any cause, which is called cryptogenic, iatrogenic. We couldn't find any cause. Till now, there is no clear causes for the liver fibrosis or chronic inflammation of many patients. Or might be chronic venous insufficiency. Many patients having portal vein thrombosis, obstruction for the venous tract. And this chronic venous obstruction lead to the chronic inflammation and chronic fibrosis, which lead to the cirrhosis. So this slide is very important. You need to know each of these diseases in order to approach the patient in the right way. When you meet any patient in the next few weeks, you have to remember all these causes. If I ask you, what are the most common causes of chronic liver disease or chronic inflammation or liver fibrosis or liver cirrhosis, you need to remind yourself about these causes. So you told me there is alcohol, there is fatty liver disease, viral hepatitis, and immunological disease, autoimmune disease. And if it's all negative, we search about metabolic causes or congenital causes. You need to understand some things about physiology, and you are better than me because you are coming from the basic. So the function unit of the liver is the hepatic. We classify the liver into loops, right and left, and then this left and right composed of liver lobules, and the liver lobules composed of acinus. Acinus, this is the functional unit of the liver. If you can see, this is the hepatic acinus. What is the difference between this region? Each hepatic acinus composed of portal triad, which composed of the portal vein, branch of portal vein, a branch of hepatic artery, a branch of bile duct. But if you can see, and then the blood goes from the portal vein, goes in this direction to the central vein. And the central vein goes, drain to the, what? To the hepatic vein, and then to the hepatic vein to the inferior vena cava. While the bile goes in the opposite direction. So, you need to understand the territories of portal vein. So we have the liver, and we have the portal vein common. What are the territories of portal vein? Splenic vein. What? SMVs, superior mesenteric vein. Sorry, SMV and inferior mesenteric vein. Okay? These are territories of portal vein. So portal vein supplies 70% of blood supply to the liver. The other blood supply for the liver is hepatic artery. So the only organs have dual blood supply is the liver. So the ischemic insult for the liver is very rare. That's why we couldn't see any liver ischemia like the heart or the bowel, like the liver. The liver have dual blood supply. It's very rare to have ischemic insult because he has two dual blood supply. But on the other hand, all the blood drained from the bowel all the blood comes from the bowel, it has to pass to the liver before it goes to the systemic circulations. So all the process of metabolism, it's happening in the liver. So any toxic insult, like mushrooms or drugs, it has to pass the liver until it goes directly to the systemic blood supply. So the function of the liver is very important. So imagine if the blood enters from the bowel is full of the nutrient and full of the toxin. So it enters to here. So that is why the zone 1 has good blood supply. The process of anabolism will happen in this and bile salt formation. While zone 3 is away from the blood supply. Process of the catabolism will happen here, lipolysis, glycolysis, and that is why the liver have patchy, because of this, the liver have patchy inflammations. So in the liver, there is no diffuse inflammation because the toxins attack the portal tract first. The ischemic insult attack the central, around the central venule first. What are the cells of the liver? The liver is composed mainly from hepatocyte, 80%, and endothelial cell, which is lining the sinusoid, as you can see here in the pictures. And epithelial cell, which lining the bile duct. This is the function unit. And then there is what is called kufa cell, which is the macrophage, which is the weapon of the army of the liver, and we have stellate cell. Stellate cell, all the pathophysiology and all the research and all the data coming from the studies focus on the stellate cell that play a major role in formation of liver fibrosis and keeping the liver fibrosis. We're going to see this. So in physiological function of the stellate cell in the physiology, normal physiology, is only store the vitamin A, regulate blood supply, and defend against pathogen. But when there is liver insult and there is a liver inflammation, this cell will convert to the myofibroblast and can produce collagen for the liver. This is a busy slide. I don't need you to worry about this, but you need to understand when there is stellate cell activations by cytokines from the hepatocyte, kufa cell, late lymphocyte, there is perpetuations of this activation. So it will form a vicious cycle of activations, as you can see in this diagram. Then, how the fibrous band forms, the activation of stellate cell leads to the production of collagen cell. Again, the fibrosis continue because of inhibitions of enzymes. This is TIMP enzymes, which inhibit the collagen breakdown. Then the inflammation continue and the fibrosis continue by secreting another cytokines. And then, of course, the activated cell will lead to release of endothelin, which is for the main pathology, the main cause behind the pathophysiology of portal hypertension. So just this slide in order to understand why the fibrosis, once the inflammation is happening and continue, the process of fibrosis will end in the vicious cycle. I will not stop until you close or cut this cycle by treatment of the cause. This is the idea behind the liver fibrosis. So many patients, they have fatty liver disease. And the fatty liver disease causing steatosis, accumulation of triglyceride inside the hepatocyte. And this abnormal accumulation leads to trigger of an inflammation inside of hepatocyte. And then if this triggering of hepatocyte lead to the inflammation, and this activation of stellate cell, releasing of cytokines, keeping activation of stellate cell, then stellate cell become myofibroblast and production of collagen. Then once the collagen is produced, it will lead to formations, activations of further activation of stellate cell and the preventions of degradation of collagen, and then the process will continue until the patient is having liver cirrhosis and he or she doesn't know. So that is why it's very important to screen our patients, whatever the cause, and I will see what is the plan, our plan in order to approaching the patient in the right way. So this is the aim of the stellate cell and keeping the liver fibrosis. So the dangerous, as I said before, the liver is having two blood supply, which is very good things. But the bad things, once the stellate cell is activated by any inflammation, it will keep continue to produce fibrous and collagen and will not end until you cut or stop this vicious cycle. Okay, we will come to our target, which is the clinical, because you are a medical students working in the clinical world, and you need to understand some things. This is the first half of the lectures is about pathophysiology, but you need to understand what's happening in patient with cirrhosis. So in patient with cirrhosis, there is clinical scenario, clinical symptoms happening. So the first thing is the portal hypertension. We're gonna see why the portal hypertension is happening in patients with cirrhosis. But when the portal hypertension happens, there are certain symptoms you need to search about, you need to ask your patient in order to catch the symptoms of the patient with cirrhosis. And sometimes the patients come with these symptoms and you need to do your workup or a clinical examination to see whether this patient is having liver cirrhosis or not. So, the portal hypertension usually causes variceal bleeding or hemorrhage. What are the varices? Why is happening in dilated vein?
Shifting from portal hypertension to...
Yeah. So simply, when there is an increased resistance because of the liver accumulation of collagen and fibrous band inside the liver, so usually there is an increased resistance to enter the blood supply. So the blood tries to enter the blood to the liver, but there is increased resistance here. So it tries to escape, goes back to find any route for systemic circulation to reach the heart and goes back. So there is two sides for communication between the portal tract circulations and systemic circulation. What are they? So lower esophagus, and the second? Lower rectum. Okay? So that's why patients with liver cirrhosis, usually they comes where? They comes with the variceal bleeding, with melena and hematemesis. So a patient with liver cirrhosis, many patients with liver cirrhosis goes to the emergency department, having melena and hematemesis. You know melena? What are the definition of melena? Okay. So black, tarry, soft, offensive, shiny stool. Okay? This is the definition, 5. So when the patient is having black, tarry, offensive, soft, glistening stool, so usually they goes to what? To the emergency department. Or having hematemesis. What is the hematemesis? Vomiting of coffee ground blood, coffee ground, because the aim behind melena and hematemesis is the what? Is the digested blood. Digested blood. Because you need to be digested in order to be sure that this patient is having GIT source. Okay? So it has to be digested by the acid. And when the blood is digested, why it is become black? Why the patient with melena have a black stool? Yeah? You take iron pill. Have you anyone of you having iron pill? So the iron pill also covered these stool with black stool. So hemoglobin composed of heme and globin. So the heme, when the red blood cell RBC become digested. It will lead to the release of hemoglobin. And then the hemoglobin will be cut to the iron and globin. Globin will lead to the increased urea to the side. The iron will lead to the productions of black stool, okay, and coffee ground stool, the iron. So this is it. Because of the lysis of the RBC by the acid, then the hemoglobin will be lysed again and form globin, lead to the formation of urea, and the iron will lead to tinge of black. This is the answer. So, when the patients, many patients presented to the emergency department with melena or coffee ground bleed, when the first things you come to your mind, this patient might have liver cirrhosis. Especially if the patients have painless melena. Painless melena, because the peptic ulcer, the another differential diagnosis, usually they have abdominal pain. While patients with cirrhosis, they don't have abdominal pain. Usually they have painless melena, okay, or hematemesis. The another differential, the other features of liver cirrhosis is ascites. Ascites, what is the ascites? Excellent. So accumulation of the fluid inside the peritoneal cavity. So the patient usually they have ascites. This is all caused by the mechanism of portal hypertension. The third manifestation is hepatic encephalopathy. Is the confusion, disorientation, and reaching to the level of coma. So these are the features of the portal hypertension caused by liver cirrhosis. There is other way of manifestation of liver cirrhosis in the patient through reduction of the function of the liver. And when there is a reduction of the function of the liver, it leads to the jaundice. And of course, for hepatic encephalopathy. So hepatic encephalopathy can be manifested in two ways, either because of portal hypertension or either because of hepatic encephalopathy. So from this, you can understand all patients, most patients, 99% of patients with liver cirrhosis are completely asymptomatic. When it's going to become symptomatic? When there is decompensated cirrhosis. So we have stages of liver disease, chronic liver disease, compensated cirrhosis, whether the patients have varices. When you do the OGD or gastroscopy, you're going to find either small varices or not. But the patient doesn't have symptom. When the patient has symptom, like in form of variceal hemorrhage, ascites, or hepatic encephalopathy, we say this is a patient have decompensated cirrhosis. Okay? We have another stage, which is further decompensation, refractory patients. Either recurrent variceal hemorrhage or hepatic encephalopathy, refractory ascites, hyponatremia, hepatorenal syndrome, coagulopathy, and jaundice. And then, if the patient doesn't treat it well, it will culminate in death. So these are the time lifelines of patients with liver cirrhosis, starting from chronic inflammation, it's simple, fatty liver disease, viral hepatitis, alcohol intake, and then it will finish by cirrhosis. And keep in mind, the cirrhosis might be happening in any patient and have full-blown picture of liver cirrhosis, and the patient doesn't have symptoms for a while, for years. For years. When it's gonna have symptoms? When they have decompensated stage. And it manifests either in form of the melena or hematemesis, ascites, or hepatic encephalopathy. There are some general symptoms we're gonna see there, but the main message for you guys from these lectures, patient with liver disease or fibrosis doesn't have symptoms. They might have fatigue, some fatigue, but usually 99% of those patients, they don't have symptoms at all. Okay? When they're gonna have symptoms, then at the end, when the patients have decompensated stage. Okay. So we have many features of liver cirrhosis. Many features. So, and especially the chronic liver signs. And you need, when you have a suspicion, imagine yourself, you are working in the ED department and the patients come with you with hepatic lymphoma or melena or Azeez. So you need to do some history intake and some examination, especially the general examination, to see whether the patient had a chronic liver sign or not. And there are plenty of liver signs, chronic liver signs. So I told you one case, one story. Some of days, a female coming to my clinic, she's suffering from ascites. And do you know the other causes of ascites other than the liver cirrhosis? The most common cause. I asked the students in year 4, here I speak about the most common cause, and only a couple of students answer me. We have 3 most common causes of liver of ascites. Heart failure,
cirrhosis, or malignancy.
Excellent. So these are the most common causes. So 90% of patients presented with ascites, they have one of these 3 causes. And there are rare causes, other rare, like ovarian tumors, hypothyroidism, pancreatitis. But when you met a patient with ascites, so remember the 90% of those patients having 3 of those causes: heart failure, liver cirrhosis, and because just we did the examination last couple of weeks for your colleagues in year 4. Ask them what are, I mentioned this the same time. What are the causes, most common causes? 2 or 3 of couple of students answer this question. Okay, so the lady, it is about 65 years old lady coming with ascites. And she consult one of the cardiologists. And because of the treatment is the same, so he told her she got heart failure. And she become approved on diuretic because the diuretic is work in the cirrhosis and work in the heart failure. But all of a sudden the patients become massive ascites. She become massive ascites. As you know, when the patients have massive ascites, so usually the patients, usually the patients have liver cirrhosis and the patients need to do the peritoneal aspirations. While patients with heart failure, usually those patients respond, the ascites for heart failure, usually the patient responded on diuresis. So once I put the probe of ultrasound on her, I found the shrinkage liver, small liver, and bloating in the liver. And the echocardiography I did for her is completely normal. So the diagnosis depends on, again, when I do the general examination, I found palmar erythema, found spider nevi, dilated veins, all the features of chronic liver signs which aid you in the diagnosis. Before you're gonna do the ultrasound, you can do the examinations and you found there's a tinge of jaundice, hepatomegaly, jaundice, ascites, spider nevi, palmar erythema, sometimes cyanosis, endocrine changes in form of gynecomastia and testicular atrophy and impotence in male. While in female, breast atrophy, irregular menses, and amenorrhea. So these are the features of, most of common features of patients with the liver cirrhosis. Bruising, purpura, epistaxis, portal hypertension, form of splenomegaly, caput myosa, and encephalopathy, and some pigmentation, digital clubbings, and the refined contraction. We're gonna see all of these features. But what I need you to understand here is when you have a suspicion for a liver cirrhosis, you need to do the general examination to look for all these signs. You need to see the palmar erythema, look for the jaundice, for the gynecomastia, for all these signs that you need to increase your suspicion about liver cirrhosis. Again, we spoke about pathophysiology of portal hypertension, increased resistance, it leads to the portal hypertension, and the portal hypertension lead to the vasodilatations of capillaries of the bowel. And then the blood will be pulled in this dilated capillaries inside all the bowel, and it lead to the hypotensions and hypovolemia. And then when there is systemic hypovolemia and hypotension, it will lead to the activation of renin-angiotensin system. And this lead to the water and sodium retention. And then will lead to the increased cardiac output and increased flow to the blood, to the liver, and of course, it lead to the more, again, vicious cycles of ascites on the portal hypertension, or hepatic encephalopathy, or variceal. So look to what's happening is a vicious cycle. Just we will start with an increased resistance of the blood intake to the liver, will lead to the vicious cycle unless you cut the process and you treat because and stop this cycle from happening. Ascites. One of the cases that we bring in the examinations is the ascites. The ascites is accumulation of fluid inside peritoneal cavity. When it will be evident, clinically evident, when the fluid more than 1 liter, it becomes evident. And you're going to see that when you lie the patients on his back, you're going to see buffness of the lines. When the patients have tense ascites, even you will see the everted umbilicus and tense ascites, like this patient. He has umbilical hernia, become more dominant, and you will see there is a tense ascites causing eversion of the umbilicus and productions of umbilical hernia. How we diagnose ascites? How we confirm there is ascites or not? I will tell you, one of your colleagues said, if this female, it will be pregnant. As you know, we have 5F for abdominal distension. No? Yeah. So how we confirm the diagnosis, whether this is a fluid accumulations or fetal. Excellent. So shifting dullness and transmitted flow. These guys, when you come to the ward, you need to practice yourself, familiarize yourself how to apply this science, how you do the shifting dullness and transmitted flow. Because half of you in the exam, they have no degree about this science. They don't know how to do the transmitted flow. They don't know how to percuss for the ascites. So you need to familiarize. This is one of the skills you need to learn about how to confirm whether this is a fetus, whether this is a fat, and what is the against? If I told you this is obesity, what is against? What is other sign you can see before you do shifting dullness? ما بصير لا نعمل بيكتشر جاي تشوفوها dilated vein يا والله نفس الكيس جري ابو جماعه على الابدومينال وول عنده dilated vein اللي ما شوف وبعد another sign inverted umbilicus واكو هاي فوق الانفيرتد بي عنده umbilicus فالكيس اللي جبته انه عنده inverted umbilicus. What is the other signs of that confirm this is a tense ascites? You have to say this is everted or herniated umbilicus, which goes with what is called ascites. So there are many causes for ascites or pathophysiology. In addition to the portal hypertension, there is reductions of the albumin produced from the liver, and then it will lead to the reduction of oncotic pressure. Of course, we just spoke about subtensions and sublytic vasodilatations, and also lead to the aversion of the fluid from the liver, from the capillaries to the peritoneal cavity. So here are some of the pictures for more of the chronic liver signs. One of the most important representation of patient with liver cirrhosis, I told you, is the varices. Look to the engorged vein here. There is engorged vein and submucosal in the lower esophagus, which means the patients have significant portal hypertension and significant liver fibrosis. And this is a patient have liver cirrhosis. And if this patient, what we will usually do, we ask the patient to do screening. After we diagnose, we confirm the diagnosis of cirrhosis. We will ask the patient to do screening OGD to see whether he has or she has varicose vein. And if he's positive, we will do esophageal banding in order to prevent the further bleeding of these patients and save life for them. Portal hypertensive gastropathy is like a snake skin appearance, as you can see. This is the appearance of the mucosa inside the gastric and inside the stomach. So this is might cause iron deficiency anemia and sometimes cause dyspepsia. So the patient presented with hypertension because of the engorgement of the blood, because of portal hypertension, it will lead to the portal hypertensive gastropathy. Dilated vein. Why the patient have carbotamidosing? What? On what is the source of the orthosystemic circuit? When the anterior abdominal wall. Excellent. So, in umbilical life, the fetus fed from the mother through the umbilical vein. The blood comes from the mother, enter to the fetus through the umbilical vein. After the delivery, we clamp this umbilical vein and become rudimentary cord. There is no veins at all. But in patient, imagine, because of increased pressure inside the portal tract and the blood try to escape to the systemic circulation, the recanalization of this rudimentary vein will happen. And the blood goes through the umbilical vein and found a communication with the systemic superior vena cava and form a carbotamidosal and dilated vein, like in these pictures. So if anyone asks you, what is the source of blood or the source of the dilated vein in patients with the behind carbotamidosal, you can say there is a recanalization of the rudimentary umbilical vein, which is the main blood supply for the fetal life during the period life. Okay? Jaundice. Look at the statement. When it is first appeared, it is due to primary to the failure to secrete bilirubin. Anyone can explain what is the meaning of this statement? What is the meaning of this statement? This is a golden statement. In many cases, I'm diagnosed because no one understands this statement.
Gradually increase. Gradually increase.
When first appear, it may be caused by failure of excretion of the bile. If you return back to what I told you in the pathophysiology of the symptoms and signs happening in patients with liver cirrhosis, I told you either because of portal hypertension or either because of the liver insufficiency. So what do you think? The liver insufficiency in patients with liver fibrosis happening initially? At the end of the day, at the end of all the process of the liver fibrosis. So patients have liver cirrhosis for ages, which is undiagnosed. Then when we diagnose them, we treat them and we will delay the process of the reduction of the function. When the patient's reaching to the final stage, of the liver failure, then the bilirubin become increased. So when you have your patients visiting you every 3 months or 2 months, having liver fibrosis, when he starts to develop jaundice, you will put a large question mark on this patient. You will gonna need to discuss the liver transplantation, because this patient, at any day, he might lose his life, because the liver, the function unit of the liver become diminished, and this function of unit is inflamed, and it will not help the patients. But when it first appeared, when the patient presented with cirrhosis and he had got jaundice initially, he might have biliary causes of liver cirrhosis, primary biliary cirrhosis, primary sclerosing cholangitis, which is the main initial presentation is jaundice. You understand what I mean? So there are some causes of the liver. It can cause jaundice initially, like the primary biliary cirrhosis, primary sclerosing cholangitis. While not like the jaundice that's happening after the impaired function of the liver, which needs years in order to develop. So when it first appeared, when the patients having cirrhosis are presented with jaundice, so you need to think about this patient might have a biliary cause of the liver cirrhosis, or either he might present it at the end of the day, or end of his liver cirrhosis. This is what I mean by jaundice, because you need to focus on the case, because in patients presented with diagnosed liver cirrhosis and the patient has jaundice or told you I have itching, so you need to think this is a patient have cholestatic causes of liver injury. You need to search about it. You need to send the patient for ultrasound. If it is negative, you need to send the, especially if the patient have liver deranged function, which goes with the cholestatic liver function. What are the cholestatic liver features on liver ultrasound? What are the liver function tests? So ALT, which is equivalent to the GBT, AST, which is equivalent to the GOT, ALP, GGT, and total serum bilirubin, which is contained direct and indirect. So these are the functions, these are the elements of the liver function test. When you are gonna say either this is hepatocellular liver injury or cholestatic liver injury or mixed pattern. Anyone? How come? Yes, you are speaking right, but I need reference numbers. Do you know the normal range for this enzyme? So usually those enzymes, usually 40, up to 40 kilogram. The early up 120, or some books 150, and some pediatric 170. So the definition of hepatocellular hepatitis or deranged liver function, when the ALT and AST more than 5 times of normal, and the ALP and GGT less than 2 times of normal. We call it hepatocellular or transaminitis or hepatic deranged liver function test. On opposite, cholestatic, the ALT and AST less than 2 times of normal, the ALP and GGT more than 5 times of normal. So this is the definition of what? Cholestatic liver, obstructive cause of liver. Of course, this goes with indirect bilirubin, but don't depend on bilirubin. Bilirubin is misleading you. our surgical colleagues depend on the bilirubin, but we are a gastroenterologist, we depend on enzymes because it's more precise. So, if the definition not applicable on each this, we call it mixed pattern. If the definition not applied on ALT more than 5 times and ALP less than 2 times, so on the ALP more than 5 times, on the AST less than 2 times, so we call it mixed pattern. So I bring a case one years that the AST and the ALT 350, ALT 380, while the ALP about 600. So what do you think? This level is hepatocellular, sorry, 500. Hepatocellular or cholestatic or what? I'll say. Khalid said. Sean said. لا والله عندي محاضرات في الجامعة. So what do you think, guys? This is hepatocellular. This is mixed. This is cholestatic. صدق سيدي بعد أصلا جاوبوا. ليش؟ AST and ALT, what is the normal? 5 times 200. Is it above 5 times or not? ALP 500. What is the normal? 150 or 120. How much? Less than 5 times. It's 4 times. So most of the students at this time, they answer cholestatic because they saw the ALP is 500. They don't know the normal range, as I told you, is 120. So all they failed, unless 2 or 3 students, they failed to solve the case. So you need to understand the normal range. The ALP have higher normal, 120, while the ST and the ALT having normal value of 40. So 350 it means this is hepatocellular cause. Okay? It's silly, but you need to think. So the hepatocyte, the hepatocellular hepatocellular liver deranged liver function test, which means that the hepatocyte is inflamed. It means the ALT and the ST more than 5 times, while the ALP need to be less than 2 times. If the cholestatic, you need to the alkaline phosphatase more than 5 times. If the definition not applicable, then will be the mixed. Hepatic encephalopathy is the dysfunction of the brain, and usually because of the accumulation of ammonia. The ammonia lead to the separation of the patients with the liver cirrhosis, and the patient start to develop. We have 4 stages of the liver of the hepatic encephalopathy, starting the patient from changing his sleep pattern. So the family told you they become more sleepy at daytime. The behavior become so slow, and the memory will be lost, and they become disoriented to the time, place, person, and then at the end of the day will result in the coma. He lost consciousness. So the other scenario, the other cases that usually you face many patients presented with coma, they goes to the neurological department. and they do CT for them because they lost their consciousness, and they found no CT scan for the brain. And then, when the blood test comes, there is biochemical evidence of liver cirrhosis, and the patients at this time will be referred from the neurologist to the gastroenterologist and hepatologist in order to approach him in the right way. Okay? So remember, the patients with coma, one of the differential diagnoses of them is liver cirrhosis. There is a new era about dysbiosis, bacterial dysbiosis. Anyone knows about dysbiosis? What is the dysbiosis? What is the term of dysbiosis? The bacteria in the colon and in the bowel, the small bowel and the colon, we have commensal and harmful bacteria. The gut and the lung create for us an equilibrium between those commensal and harmful bacteria. But in certain cohort of patients, certain group of patients, this equilibrium become disequilibrium, and the harmful bacteria become more than the commensal bacteria. They are living in peace because the number and the types of the commensal bacteria is outweigh the harmful bacteria. But for some of the reason, patient taking a lot of antibiotic or long-term antibiotic, this causing this bacteria, commensal bacteria, to be reduced or killed. Then the harmful bacteria will become more than the commensal bacteria, causing what is called bacterial dysbiosis. And this bacterial dysbiosis, we found many patients with liver cirrhosis, they having bacterial dysbiosis. The harmful bacteria is more than the commensal bacteria. And this term, and this is especially in patients with hepatic encephalopathy. That is why one of our treatment for a patient with hepatic encephalopathy is antibiotic in order to kill the harmful bacteria. Okay? No one knows. No one knows why the commensal bacteria reduce. But because of the congestion behind the portal hypertension, because of the sublantic vasodilatations, because of the stasis of the blood happening after portal hypertension, all these causes might be behind the portal hypertension of the bacterial dysbiosis. Pulmonary erythema is the erythema above the thenar and hypothenar muscles. It's very simple sign. We need to remember. I asked one of the students in the exam, just give me 2 signs in addition to this ascites in order to confirm the diagnosis. So you need to tell me that I need to do general examination to look whether the patients have pulmonary erythema, look to the chest to see cider nevi, look to the gynecomastia, look to a lot of signs. But it is a pulmonary erythema, it's happening hyperdynamic circulations, it can happen in malignancy, and in healthy athletics, and it is a normal variant in some people. But it is one of the essential signs in a patient with liver cirrhosis. Spider nevi, as you can see, there is a spider, and there's prominent capillaries, arterioles. When you press the center of this spider, all the spider will disappear. It has to be more than 3 in order to be pathological, because 2 is usually can happen in healthy person. So it has to be 3, more than 3, in order to say this is a pathological spider nevi caused by the portal hypertension of the liver cirrhosis. Okay? Usually we found on the territories of superior vena cava. Gynecomastia, enlargement. Why the gynecomastia happening in patients with liver cirrhosis? So the estrogen become more dominant on the level of androgen in the male and causing gynecomastia. But is there any causes of gynecomastia in patients with liver cirrhosis other than the dysfunction of androgen? Excellent. Spironolactone. So the answer, the question is, how we can differentiate this gynecomastia caused by aldosterone or liver cirrhosis? Excellent. So because of accumulation of salt secondary to the aldosterone, so it's usually patients with aldosterone having tender gynecomastia. So when you stop or change the aldosterone, the gynecomastia and pain will disappear. Okay? So this is the usual. So how we differentiate between gynecomastia? This is a very important concept. You need to understand. Patient with aldosterone usually having tender gynecomastia. While patients on just cirrhosis, they don't have pain. Clubbing can happen in patients with cirrhosis, especially with hepatopulmonary syndrome. Terinail, whitening of the proximal part of the nail, can happen in patients with liver cirrhosis. Okay. We finished the clinical signs. You understand your patients have plenty of liver signs. Chronic liver disease, of liver disease, chronic signs for liver disease. So we have plenty of them. So when you examine the patients, you find ascites or palmar erythema also in general examination. You need to track the patients. You need to examine other parts. Look for spider daylight or gynecomastia, examine the genitalia, look for the muscle wasting, look for bruising, look for epistaxis, look for all these features. It can help to find like 2 or 3 signs in order to help you diagnose the patient with liver cirrhosis. If you confirm or you have high suspicion of liver cirrhosis, you need to do some investigation. On the top of that, we, as you know, we start with simple investigation. What do you say in the patient? CBC. What is the content of CBC? You know? أول شيء واحد BC فوق بعد شنو مجاوبين؟ يا أخي والله سألناهم هذا السؤال ما عرفهم بس أنا بدي أعيدهم على مود أثبتكم براسي مو أنت تجون الامتحان ما في واحد نايم واحد قاعد يسولف هم من اللي انصادموا؟ أسأل كم واحد قاعدين يسولفون كم واحد نايم هذول اللي انصادموا غشهم زين بس اللي منتبه راح يجاوب اللي منتبه راح يجاوب اللي نايم ومدلغ وباله في الغير ومشطل وما ادري شو يسوي هذا هناك نصيده ان شاء الله بس هي الفكره مو بالصيده بالامتحان ما الفكره انه you are a medical doctor after you graduate you are sitting in the ED in the ward you will hazard community if you don't be efficient فهمتوا علي؟ you become a hazard you are a killer if you don't know this ABC of medicine. If you don't know this ABC of medicine, you become a killer rather than you save life. So some of you, they come to the faculty of medicine to enjoy their life. It's not this is the case. You need to take the opportunity and take the responsibility because you will hazard the community after you graduate. Many problems happening and you support our junior doctors. Many problems happening in the health. I told you one story. I have a patient in patients, admitted him after intervention endoscopy. He has got bleeding, and we clipped this duodenal ulcer, bleeding duodenal ulcer. I asked the junior doctor, we don't have permanent doctor, asked him to monitor the patients. And there is any hypotension or any vital sign compromised, he called me in order to see, because the patient might bleed at any time. And we need to introduce. Do you know the patients having cold extremities and shock and malign, and he doesn't know anything about the approaching the patient's vital sign. The patient starts initially by having borderline high blood pressure, 110 over 70. Pulse rate is 90 start. This is the initial. I saw his chart, he's writing the chart very well, but he doesn't know the sense. Then the blood pressure become 110 over 60. Pulse rate become 105. Then the pulse rate become 115. Then cold extremities, then sweating. And he doesn't call me. Because he doesn't know that the patient is losing blood. And he doesn't know that the patient has postural hypertension. If he starts the patient, the blood pressure is 70 over 50. But he measured the patient blood pressure while he's dying. And he doesn't having the sense that the pulse rate is increasing and showing the card and calling. Until the patients have cold extremities and the family. So, and then he asked him to call me. When I call him, what's happening? He said that the pulse rate is 115. The pulse rate. So this is the disaster. I opened the theater at 12 a.m. in order to solve the patient. I bring the patient back. He wake me at the middle of night in order to solve the patient's problem. Look, simple information. Chart, vital signs, very simple. You do not know. So, CBC, contain white BC, hemoglobin, and the platelet. So, if you catch a patient with pulmonary erythema or ascites, or the usual scenario goes to the emergency with malign or hematemesis. So you will find platelet low. So what does that mean? Thrombocytopenia. And what are the causes of thrombocytopenia that you know? So thrombocytopenia is the initial sign, biochemical sign for liver cirrhosis. Thrombocytopenia is the initial sign, remember this, is the initial biochemical signs for a patient with portal hypertension. So what are the mechanisms? We have two mechanisms. Either sequestration due to a large spleen, okay, or either because of the reduction of thrombopoietin hormone secreted from the liver. So you might encounter a patient with low hemoglobin, especially if the patient has bleeding varices, or you might encounter a patient having blood platelet. Or many patients, we receive many consultations from the hematological colleagues regarding the patient have low platelets. But because the hematologist, one of other important causes of low platelet is the ITP, immune thrombocytopenic purpura. So when the hematologist screens those patients and doesn't find any source for ITP, so he sent this patient for us in order to confirm whether the patient has liver cirrhosis or not. So CBC is very important test for a patient with liver cirrhosis. Why? Because we can find low platelet. Of course, if the patient has iron deficiency associated with bleeding or gastropathy, or might have white BC increase, which gives you suspicions of infection concomitant with the patient with liver cirrhosis. Okay, so thrombocytopenia is the initial biochemical signs of portal hypertension, which is widely common in a patient with liver cirrhosis. Again, the patient might be presented with low platelet only, just, and he need or she need high index of suspicion. زي هذا الموضوع. So remember, I need you to understand these words. The thrombocytopenia you can catch a CBC with low platelet. When you see the low platelet, you have a suspicion this patient might have cirrhosis, liver cirrhosis. We need to do the other signs of another biochemical work. The another question, what is the enzyme specific for hepatocyte? Which is the specific for ALT. So ALT is more specific for hepatocyte. When there is elevated liver enzyme in form of ALT, so the enzyme, the cause usually cause hurting or harming the liver. But in patients with start to develop liver cirrhosis or fibrosis, there is a reverse ratio. The AST become more prominent on ALT. So when you see a patient having AST more than the ALT, you will have a suspicion this patient have liver fibrosis. Okay? Other sign, biochemical sign is low albumin. Other is high iron ion and increased bilirubin. All these biochemical evidence, it will aid or it help you to diagnose liver cirrhosis and give you. It is not pathognomonic, it is not only the cause for these abnormalities, the liver cirrhosis, but you need to keep in mind that if you encounter any of those signs, or in fact, it can help you to confirm the diagnosis of patients with liver cirrhosis. Okay? Again, imagine this patient with low platelet, you encounter a patient with low platelet, and the hematologist sent for you, or you send me a case, and you ask me to check whether this patient have liver cirrhosis or not. I did all the features of the chronic examination. I didn't find one chronic liver sign. Or I might have one or two, like pulmonary edema or gynecomastia. What is the next step? You need to do more sophisticated scale examination in order to look for the degree of fibrosis. On the top of that is the liver fibroscan, which is called transient elastography. What is that machine? It's a machine send a vibration in order to look for the what? To look for the stiffness level. If you see here, what is called the stiffness level, because I'm sure all of you have eaten the liver. اللي يمسح لك شد زين. It is very soft, the liver, before you cook them or before you fire them. So you need to, if the patients have some fibrosis, so the stiffness level will be increased. And then the machine will give you a higher number. And we have like more studies show for us that this number, it can give you a hint about the degree of fibrosis, like the Metavere score. They are F1, F2, F3, F4, and F4. So according to the numbers of fibroscarism. Nowadays, we depend on fibroscan, and we do not do any more liver biopsy in order to confirm the diagnosis. But liver biopsy, we need it nowadays to know the cause behind liver fibrosis. If you search all what I told you, the autoimmune, the biology, and there is no alcohol intake, the ultrasound was normal, you need to do the liver biopsy in order to confirm the cause of the liver fibrosis. So this is what is called fibroscan, transient elastography, which can help you to assess whether the patient have liver fibrosis or not. Another modality to confirm the liver fibrosis is ultrasound. ultrasound, we can catch two criteria for liver fibrosis and liver cirrhosis. We have features of portal hypertension, and we have features for liver fibrosis. The first feature, as you can see, the feature delivered on this panel is homogeneous liver. And it is the increased it's homogeneous in the normal. But this is a heterogeneous. This is more black here, this is more white here, this is more black here. But the color here is normal. There is some biliary duct, hepatic vein branches, but all the livers look homogeneous in color. In liver cirrhosis, you can see there is heterogeneous liver, an increased echogenicity, whiteness of the liver. Third, it becomes nodular surface. While look to this edge, is sharp, smooth edge, while here is nodular liver. Look to the size of the liver, and look to the size of the liver here. As it shrinks. On the opposite, the kidney. Right kidney. This here, and the other diagnosis is the prominent of the caudate loop, which is happening which is lying on the left loop, caudate loop, and the shrinkage of the right loop. So this is criteria for patient with liver cirrhosis. Anyone can answer me, what is the most pathognomonic features in these signs which happen only in the liver cirrhosis? أكو إجابات صحيحة إجابات Okay, so you are right. Two signs pathognomonic for the liver: shrinkage liver, small liver, which is only happening in liver cirrhosis. And the second, nodular liver. Unless there is nodular side, sometimes we have hemangioma or mass in the liver, causing just one side to be nodular. While all the liver, if it's become nodular region, especially on ultrasound like this one, with a small, is pathognomonic for the liver. One of you is saying, why? The heterogeneous texture, increased echogenicity. Do you know where it can happen? In fatty liver disease. Fatty liver disease become more fat, there is more whitening, increased echogenicity, and it can happen on the patchy nature and causing heterogeneous texture. Okay? In addition, we have sonographic evidence of portal hypertension. راح تلاقي in the patient ascites. Like this patient, there is ascites. This is the black. This is all surrounded by ascites, Morrison pouch, and this is all ascites. So ascites, splenoidal. You can see varicose vein, portal vein. Portal vein start. This is the main features. Portal vein become dilated, reverse flow. Looks of respiratory changes, anti-pathological flow. As I say, nowadays we rarely do the liver biopsy in order to confirm the diagnosis. We do the liver biopsy in order to reach the cause behind the liver fibrosis. I put some information about the treatment. If anyone asks you, how do you treat a patient with liver cirrhosis? Usually, as I told you before, you need to cut or stop the vicious cycle of progressive fibrosis. How we do that? We treat the cause, treat the source of inflammation. So the first job of you is to reach the cause. The second is to treat the cause. how we do that? Like if the patient have autoimmune liver disease, we give him autoimmune immune suppression medication. If the patient have viral hepatitis, we treat the viral hepatitis. If the patient have hemochromatosis, we do for him flubitomol. If the patient have primary biliary cirrhosis, we give orzo deoxycholic acid. If the patient have Wilson, we give him penicillamine, thiamine, or zinc. So treatment of the cause will stop the patient converting, and we can postpone having liver transplantation for years. The second job of you as a doctor is to treat complications. So ascites, you need to ask the patient to reduce sodium intake. And if the patients have large ascites, you can start with diuretic. Paracentesis, and in refractory ascites, we can put a stent between the portal vein and the hepatic vein, close to the suballar vena cava, the so-called TIPS stent. Hepatic encephalopathy, usually we treat it by antibiotic anticoagulants. Esophageal varices, we give a medication which reduce the portal hypertension like Indirap, Carvedilol, and rubber band. Hepatorenal syndrome, we increase the volume by a plasma or fresh frozen plasma or albumin, avoidance of diuretic, and of course, at the stage of hepatorenal syndrome, the patient reaching the stage for liver transplantation. So, if you want to solve the patient and return the patient to a young adult, like normal liver, you need to do the liver transplantation. So this is the main treatment of patient with liver cirrhosis. Many patients suffering from pruritus. So in patients with liver disease, because decreased excretion of the bile and accumulation of bilirubin and bile salt lead to the accumulation. So that's why we give bile acid sequestrants like cholestyramine, antihistamine, ammonium lactate, orzo, all these rifaximin, opioid, gabapentin, all these will reduce the symptoms of itching. And even we reach to the level to do plasmapheresis or ultraviolet light therapy. Zinc deficiency, which causes nausea for a patient, and you need to treat because many patients have zinc deficiency in patients with liver cirrhosis. Osteoporosis, you need to measure the level of vitamin D because many patients with liver cirrhosis having malabsorption of vitamin D, and then you need to put the patient on supplement. Vaccination, of course, in form of vaccination against hepatitis A and influenza and pneumococcal vaccine in order to prevent further complications. You need to understand that there is certain medication should be avoided in patients with liver cirrhosis, especially the NSAID, opioid, larger dose of paracetamol, chlorpromazine, valproic acid. So these are INH. These should be avoided. This is the end of the lectures for you. And here I put some slides because I give the same lecture while I'm in Australia. They have alcoholic liver disease. If you need to see this slide, maybe. So for this lectures, just for chronic liver disease. Any question? Phlebotomy is just give blood donation. Blood donation. يعطونا عندك البلد. تبرع